So just let me know when you're ready, Eileen.
All right. Well, usually I wait till 12:04. It's the
Oh, that's
magical
fine.
time, which is right now. So I'd like to welcome everybody to our Friday conference. Today we're going to have some Bartlett updates first. Just in case any of you are, just to go over this briefly. So today we'll have Bartlett updates and then an update in a case. And next week, actually, Joyce Jones is going to lead the conference and talk about her work in primary care gaps management for people living with HIV and tools that are being developed to help us do a better job in that. The following week, we'll do some updates from CROI that I will provide, but please feel free to join and chime in for the things that you thought were most exciting. And then in early April, we have a weight management with Dr. Rajagopal. Hot off the press is Dr. Debbie Prasad is going to come and talk to us about updates in pediatric cure research on April 19th. And then on May 3rd, we're going to have a hybrid in-person with food and also a virtual conference with Dr. Bob Silicano to give us some updates on HIV reservoir and cure work. So thank you all for joining today and look forward to those conferences in a couple of weeks. So now I'm going to hand it over to Sheila and Stephanie, who's with us in spirit, I
I
think,
think
but
she might be coming on.
okay, great. To go over some updates for Bartlett before our case.
Hi, everybody. Thank you for having me. And I'm pretty sure Stephanie will be able to join. So, all right. Why are my slides not advancing? There we go. Um, so just I like to do these reminders occasionally that with the CMAs, first of all, we are down 2 CMAs right now. Lakeisha is still home recovering from a broken ankle. She's doing well. I talk to her at least once a week. And then we have a vacancy as well. So if you know of any CMAs and would like to refer them to the Bartlett, that would be wonderful. Um, but there is a lot that when the CMAs are rooming patients, they're completing HRAs for annual wellness visits, hemoglobin A1Cs, med review, they're doing the OMRON as needed, PHQ-2, GAD-2, NIDA quick screen, fall questions, pain questions, etc. So it takes a bit of time to room patients. Continue to look for patients scheduled for annual checkups and HRA completion. And if you're unable to complete them during the visit, send the patient to check out with a follow-up note to schedule them for their annual checkups and indicate additional time if needed. If you complete an annual wellness visit, please get a yellow brick at one of the zones and put your name on it and the date, and we'll put it up on our yellow brick road. It really has a lot more bricks on it, and we want you to put your yellow brick on when you complete the annual wellness visit. It's not for us to come behind you and put it up there. We want you to put it up there, and hopefully we're going to fill that yellow brick road up. Just stop me if you have any questions. Please let the CMA know if you're pre-charting because they can't tell when a patient has arrived. That's kind of been on this slide for quite some time. And then when you are off, please provide provider coverage and send an email to the RNs and do an out of clinic and Epic so we know who to cover for results, prescriptions, etc. The nurses and the CMAs have resumed doing patient education groups on the second and fourth Tuesday of each month. Please encourage your patients to attend, and they can call their nurse for information on monthly topics. And then when you get here in the morning or the afternoon for your session, try to just check in with the CMAs and discuss primary care gaps, planning for the day, anything that you're going to be doing with patients. I think that it just goes a long way to keep communication flowing. Anything from this slide that you guys want to chime in on or chat about? All right, I'm going to move along then.
Actually, Sheila, I was just going to ask on all the screenings things that they're doing, are are they all individually mandated? Are they like, because that list seems very long.
They are. Every one of those is mandated.
And mandated by like
Maryland,
quality metrics or
Maryland PCP.
yeah.
We do the social determinants of health, mandate the PHQ, the GAD, the NIDA quick screen. I mean, all these things
Mhm.
are mandated.
Got it.
The Omron is if somebody's blood pressure is greater than 140/90, of course, we want to try to get, blood pressures under control. So sometimes it's just patient is rushed in, they're anxious. If we have them sit in the room and chill out for a little bit, put their phone away, try to think of something calming, maybe we can have their blood pressure be better.
Yeah,
So
no,
they
and
really are.
I was just wondering about some of that, like recentering that work in the provider visit. Like I tend to repeat the blood pressure myself too. And so just thinking about how ways to make things a little bit more team focused on that long list of things that they initially have to do. I don't know if there's points that the CMAs think are like the biggest barriers.
My concern, Eileen, is
Yeah,
that I hear you that repeat the blood pressure, but maybe other providers don't. So I need to be consistent in what they're doing in their
got
room.
it. Got it. Okay, great. Thank you.
So I've been told that providers have been educated about the upcoming chaperone protocol that will be implemented across all ambulatory clinics beginning on April the 15th. So another thing that will be added to rooming is that CMAs will be offering chaperoning on rooming for sensitive exams. And the chaperone must be present for pelvic exam, intravaginal physical therapy, and transvaginal and or translabial ultrasound procedures. So that's already in place, that there has to be a chaperone for pelvic exam, intravaginal stuff. Here's some definitions, but it's new for these other sensitive exams. So a chaperone has to be a JHM trained individual unrelated to the patient who is in the room during a sensitive exam, or in case of video visits, witnessing the exam remotely or in person with the provider. An observer is an adult family member, parent, or legal guardian who can serve as an observer in place of a chaperone for some pediatric patient exams where there is no suspicion of abuse or guardian impairment. A sensitive exam is any exam that involves body parts typically covered by undergarments. So breast, genitalia, buttocks, groin, pubic area, rectal area. This continues, and then it continues to apply to pelvic exams that we just talked about, or the intravaginal exams. Vulnerable patients are defined as an adult who is, or for any reason, unable to take care of themselves, unable to understand the consequences of their decision. So they lack capacity for decision making, unable to protect themselves against harm or exploitation, and a pediatric patient with a history or concern for abuse or guardian impairment. So just some definitions to think about as we go through this. So who can chaperone at Johns Hopkins? A clinical staff member who has received the training on chaperone responsibilities. All the CMAs, all the nurses have received the training. Medical residents and fellows are permitted to act as chaperones for each other, and then parents and guardians can satisfy the chaperone requirement for pediatric patients under 12. Who is not permitted to chaperone are physicians may not complete chaperone documentation. So it's got to be the MA that completes the documentation that they chaperone. And medical students and residents and fellows cannot act as a chaperone for their attending physician. So I know that you guys have medical residents, fellows, students with you. They cannot act as your chaperone. Parents and guardians may not act as observers for patients 12 years of age or older, and scribes may not act as chaperones. Go ahead, Jean. I see your hand.
There we go. Okay. So listen, I just wanted to talk about the documentation part
I'm
because
gonna get to that.
because I was going to say you can't sign off the note until they document it. So that's all. Thanks. Sorry about that.
Yeah. Thank
Okay.
you. Yep. I have a whole slide deck here on chaperoning.
Wonderful. Thank you.
So the summary of the major changes here are that patients undergoing a sensitive exam must be offered a chaperone. So that's going to be another part of the CMA's rooming. Patients can opt out if it's not a vaginal exam, a pelvic exam, okay? In Epic, before the procedure, they will, the CMAs will document chaperone presence was discussed with the patient and whether or not the patient declined. The patient can also change their mind. They might say, nope, I don't need a chaperone. And then they might change their mind once they're in a room with you. Or they might say, yes, I want a chaperone. And then once they're in a room with you, they might say, no, I don't want a chaperone. So just to let you know, patients can change their mind. After the procedure, if a chaperone was utilized, the chaperone must document their name in the EHR. So again, the provider can't document that Sheila Goldscheider chaperoned. It's got to be Sheila Goldscheider documenting that. Any questions before I move on? So I'm gonna put these out in the zones and probably in the exam rooms. I'll laminate it, but here's the chaperone standards. I'm not gonna read through this again. I basically told you it's a sensitive exam is considered something that you're wearing an undergarment. Otherwise, vagina, it's mandatory. Otherwise, people can opt in or out.
Sheila, hi, it's Matthew here.
Uh-huh.
Thank you for the update. I had a quick question. I saw a patient on Monday who declined to have a chaperone, and I was trying to find a box to click for chaperone declined. Is there one? And maybe did I just was looking
So
at
it's everything's in the rooming tab.
Oh, okay. I was looking on the exam
Yeah. Yep.
short smart phrase. Okay.
Yeah, it's coming up, Matthew. You're gonna see it. That's the next, it's coming up in my slides. So then here's the documentation steps. You see we're in the chaperone tab is in the rooming navigator. The person rooming the patient will document the discussion occurred and whether the patient declines. So you see down there, they acknowledge that it was discussed and then whether or not I served as the patient declined, okay? The patient declines a chaperone, document by selecting patient declined. Okay, so there's that one. And then number 3, after the visit, if a chaperone was present at any point, they should document presence by selecting yes and typing their name in the chaperone name field. If the chaperone is a parent or guardian, the staff member should select yes to indicate the chaperone was present, and then the chaperone's name in field, they can write the parent or the staff member's name. What if the chaperone name is not entered? If the chaperone presence is documented, number 2 equals yes, but a chaperone name is not entered, number 3, provider will receive a soft stop before they sign the encounter. So as Jean said earlier on, you'll get not a hard stop, but a soft stop. And this, of course, will be audited.
So it's a hard stop for GYN.
Oh, it's a hard
Because if I don't have,
vaginal.
yeah, it's a hard stop for us. And then if I don't do a pelvic exam, I have to actually go in and say no.
Okay.
But that probably doesn't apply to the rest of you.
Yep. Yep. So that is the chaperone training. Does anybody have any questions? I'm going to send that slide deck out to the providers to look at, and the My Learning link for you can go through the training. It takes about 10 minutes on My Learning, but I'll send that out to all the Bartlett providers.
And then I'll put it on our intranet as well. So then the slide deck, so then people can access it.
Yeah,
in the
I've still
clinic.
just been putting things on the Teams. Don't we still have a Teams channel for this CFAR this Friday?
There is, but I am the internet. I put things that may come up in clinic
Okay,
that makes it easy for people to access. There are bookmarks on all of the workstations in the clinic rooms for the Bartlett
Okay.
intranet. So
great. Thank you, Joyce.
yes, thank you.
So is Stephanie joined? I doesn't look that way. Okay. So I'm gonna roll on to our quality and safety comprehensive dashboard. We only have results from January. I know it's mid-March and they are supposed to be sending out our primary care data mid-March. Today's March the 15th. That's pretty much mid, but we have not received that. But I just want you to see all the great stuff here. The only thing that is not in the blue, green, purple our hand hygiene, or I mean our patient ID, and I'm not sure why we fall in there. So I've just been working with all the staff on, even though you've known somebody for 10, 15 years, please make sure you're always asking them for their name and date of birth. But everything else, guys, I just want to give you kudos again. In-basket monitoring, closing encounters, test follow-up, overall provider rating. I mean, these are amazing scores. Overall visit rating, provider communication quality, staff quality, visit wait time, staff working well together. We are exceeding in all of these metrics. So just thank you so much. And then here's some nice comments on our HCAPS report. And you all have access to this, and we put the link to it down at the bottom of this slide for you to be able to go in and look. So my experience with Dr. Chang was the very best. With Kathleen, a good patient experience was the attention they gave me from the moment I walked in. For Dr. Jones, my provider is the most compassionate and caring provider I've ever had taking care of me. Dr. Krishnan, the whole staff from my doctor, the nurses, front desk, and people who work in the pharmacy, very helpful. My experience with Dr. Bassett and the Johns Hopkins team was unexpected, not used to it, but I found a great comfort and they care towards me. Everyone here from security at the door to the entire medical staff, including pharmacy and case manager, really polite and very professional. This is truly one of the best medical staff places I've been, and I should be recognized for this. So just again, thank you all so much. It's really nice to see those. So the depression screening is a new primary care metric that we have to begin following up on. So the PHQ-2 is done. When the score is equal or greater than 3, a PHQ-9 opens up. But that is not all that you need to do to satisfy this metric. So there are other things that we need to do, and that is going to be our metric of the month for April, but we wanted to talk about it here today. And our target for this is 86.57% of the people who have a PHQ-2 that is greater or equal to 3 must have a follow-up plan. And the follow-up plan, it can be defined as an order for an antidepressant med, documentation using the DEPFU, which stands for depression follow-up, a referral order for HBS, psychology, psychiatry, care coordination with social work case management, HBS. So you see over there on the right-hand side of the screen is what you're going to do with this depression plan. Okay, that's under your depression follow-up. And note that again, the PHQ-9 and the suicide risk assessment does not qualify as a follow-up plan. The only exclusion for this is patients 12 years and older, the beginning of the calendar year, who had an encounter with the JHM primary care department. Exclusions are if somebody has a bipolar disorder diagnosis at any time prior to the qualifying encounter. But everybody else, even somebody with a depression diagnosis, you have to do a follow-up for a PHQ-2, which is greater or equal to 3. Questions? I'm gonna talk a little bit more. Okay. So again, to identify the care gap, look to see if the patient has had a depression screening completed this calendar year. The CMAs do it every time, so that should not be an issue. And the depression screening BPA will remain visible if a CMA was unable to complete the screening. And you can use acknowledge reasons as appropriate. So just some more. Depression screening has not had depression screening during this calendar year. Patient declines, not eligible, developmental delay. So those are some of the reasons that acknowledge that it wasn't appropriate. Okay. All right. So then we talked about the smart phrase documentation. DEPFU can be added to any note manually with use of .DEPFU, or if the medical provider would like it to appear in their note automatically for any positive depression screen, they can add to a user smart phrase .depression conditional. And then of note, I just talked about that. Depression diagnoses are no longer excluded. Screening still needs to be completed. This aligns with health maintenance in the BPA. Depression screening should still be completed during video visits. And patients continuing on an antidepressant medication does not automatically count as follow-up. You still have to use the .DEPFU smart phrase to track follow-up of current treatment reviewed, continue current care if no other follow-up plan is needed. So you could say that, the current treatment was reviewed and you're continuing with current care, but you have to say that. And then here are the smart phrases that you can add. And these are the things that you can do, antidepressant, here's your referrals. Would this slide be helpful in the rooms? Because I could laminate it and put it with all the other stuff.
I'm going to say yes.
Okay. Okay. All right. I know, because it's new. All right. I will pull this one out and laminate it and put it in the rooms. And then thank you for all that you do to care for our patients. Questions, concerns?
I just want to thank you. This is, a lot of things to manage and organize, and it can be hard to keep track. So
You guys, you do.
yeah, thanks for organizing it. And the chaperone thing is sort of institution wide. So there's not a ton of people on the call today, but I'll ask that that get sent out through ID administration, I think, so that everybody has access to that and knows that in the division. And then, like I said, the things that are the most clinically relevant, I'll put them on the intranet.
I'm gonna send an email of the chaperone.
Yeah, perfect. If you send that separate, I'll send that along, or whatever mode.
I'll send the email on the chaperone.
Okay.
And then the depression follow-up, that's gonna be the metric of the month for April. So everybody would, that'll be on for an entire month on the e-huddle.
Okay, perfect. Thank you.
And then I'll laminate the depression follow-up in the and put that in the rooms, because I think that'll be good to put in the rooms.
Okay, great.
Yeah, there's not many people here today. I hope we didn't scare them away.
So, Sheila, I was just wondering, so when somebody has a greater than 5 on their depression screen,
3,
um,
3.
I thought it was for the PQ, not PHQ-9, where we have to
Well, it's
actually,
a 3 for the PHQ-2.
right, then it goes
You
to the
have to
9, then if
follow
it's
up.
over
I mean,
5, you're supposed to have a plan, correct?
no, 3.
Oh, did
3.
you read that wrong? Okay,
Or greater or equal to 3.
for the
Just flip back in the
PHQ-9?
slides.
Yes.
Okay, so that's okay. So that wasn't really my question. The question was, will we be alerted to that if something pop up, or should we just always check it when they come in the room? Is there your patient has to have a follow-up for,
I think, hold on a minute.
oh, it is greater than 5. Wait a minute.
It's 3.
Wait a minute. So here's
If
PHQ-2 is
positive
greater than 3.
PHQ-2 score greater or equal to 3,
And what's the rest of that sentence? PHQ,
I think that's supposed to see a 9. When you do the 9, a score greater or equal to 5, a follow-up plan is completed.
that's what I was referring
They
to.
didn't put the 9 here. I think
Yeah,
a
that's what I was
9 is
referring to.
supposed to go
Okay.
here.
Okay.
So a 2, it's greater or equal to 3, which you used to have to do something. The old way was if you had a PHQ-2 that was greater or equal to 3, you were
Huh.
supposed to do a 9.
Right,
And
exactly.
you're still supposed to do a 9, right?
Right.
And now you have to also do this depression plan.
If it's over 9 or if it's,
Greater
I mean,
than
if it's over
3.
5, that's the confusing
3.
part.
The
It doesn't read that way,
PHQ-2
though.
greater
Am
than
I?
3, you have to do something. Just don't even worry about you got to do a 9, but you still got to do a plan.
But if your
I see.
9, if your 9 comes up as not concerning, can you stop there? I guess, is
That's
that what
my-
you're
I
asking,
think
Jean?
so.
Okay.
Mm-mm.
Thank you. Yeah, that's what I was confused about. Okay.
Yeah.
Yeah, so I would just look at it as PH2 score greater or equal to 3. I have to do this DEP follow-up.
Okay. Okay. That simplifies it.
That's my understanding of it.
Okay.
Okay. I just wanted to look at this next one. Yep, yep, that's my understanding, but I'll make sure and clarify. Thanks,
All right.
everybody.
Thanks,
Have a great
Sheila.
weekend. Take care.
All right, so we'll switch gears a little bit and go